patients. Regarding maintenance dialysis and end-stage kidney disease, this is a very recent data showing the morbidity and the mortality in different countries, including Japan, Spain, Italy, New York, Paris, and other cities. As you see, this is the morbidity rate. You can see the figure ranges from low to high value, and mortality also. There is variability in the range of mortality, but it seems that it is high for end-stage kidney disease and dialysis. And this is a smart way, a checklist for screening, management, and others. And as you see, this is the circle means availability of recommendation. NA means not available, and this is non-specific. So I think we should do our best to make everything available for our patients. Another cohort of patients showing that dialysis patient is associated with poorer outcome and the mortality is high in many cohort of patients. And comorbidities, the presence of dyspnea predict the mortality in dialysis patients. Again, fever and also the disease, high CRP, all these are clinical parameters that predict mortality in the hemodialysis patients. Clinical presentation of COVID patient may differ between patients without kidney failure and the patients on dialysis. So the fatigue is more common in dialysis in general patients, but for dialysis patients it is common, but not to the same extent of patient without kidney failure. Here, dry cough is more common in patients without dialysis. Fever is more in non-dialysis. So this is the difference between the general population and the dialysis patients. So COVID patients was associated with higher mortality. This is what we mentioned. One of the practical points, when we diagnose a case and treat the patients from COVID, we should be careful because the situation may recur. So this is not a disease of one point of time. We should follow up the patient forever to assess for recurrence of the disease. And this is a very hot issue. And I think we can raise it in the discussion. How to diagnose SARS-CoV-2, how to confirm the diagnosis, is by PCR alone or by PCR and serology. It seems in dialysis it is difficult because, as you see in this study, over 4 months, 9.6% of maintenance hemodialysis were found to have SARS-CoV-2 infection. And if you look here, 53% of cases showed PCR positive, 47% serology positive. So it seems that we need, according to this study that showed 36% seroprevalence rate, this is 356 in-center hemodialysis patients, 36.3% seroprevalence rate, 40% of patients with IgG SARS-CoV-2 antibodies had either asymptomatic infection or undetected disease by PCR testing alone. So it seems that the best way to diagnose and to confirm SARS-CoV-2 is to follow hybrid technology by antibody and PCR. But I think it will be very costly, and we should be cautious about our patients. This is a large study done in the United States. This is the number of dialysis patients in the United States, approximate 500,000 patients. 28,000 patients were selected to assess SARS-CoV-2, and it differs from state to the other. I think the best way for managing COVID is to raise the attention, to follow the infection control policy, to predict the patient, do triage, and I think Professor Hesham will discuss this point, and I would like to congratulate Professor Hesham Elsayed because he is the chief of the committee of COVID in Africa, and this is one of his publications with the other team, and the second publication will appear soon in the current issue of Journal of Research of Nephrology Transplantation. It includes very practical triaging and managing COVID patients. Very simply, we should take care of any COVID patient. We should lower the threshold for diagnosis, and it's better to isolate the patient. And dialysis, the best way is to do dialysis in negative airway ventilation. And if it is not available, the patient should be isolated after noon and to disinfect the unit after this shift. And I'm leaving this sector to Professor Hesham at the end to discuss it. It seemed that COVID-19 increased the awareness of peritoneal dialysis because peritoneal dialysis will avoid the need for healthcare workers, for doctors, for hospitals, and the patient can lead the management. But we should be careful about the effluent. And so if the patient is on mechanical ventilation, the peritoneal fluid may increase intra-abdominal pressure. So there are pros and cons, but it seems if it's feasible, it will be fine to continue in BD. Regarding dialysis, what about ESA therapy? To use ESA therapy or not in dialysis patients? If the patient is anemic and treated with ESA therapy, we should continue ESA therapy. But to be careful about the hemoglobin level. In COVID era, we can expect resistance, number one. Number two, if hemoglobin is and hematocrit is elevated significantly, this may increase the risk of thrombosis. To be careful about this point. However, to this, the contrary, this is the letter to the editor is stating that EPO may have anti-COVID effect. And this is a case where the anemia without renal failure, the patient received the EPO therapy to treat anemia. And after starting EPO therapy, the COVID state improved significantly. This is because EPO has anti-cytokine and can lead to immune modulation and reducing severity of COVID disease. This is why we should balance the weighing the risk benefit, and for dialysis patients who are treated with ESA therapy to continue, but to be very careful with adding EPO for patients who are not treated. Regarding transplantation,